Good afternoon. My name is Madison Lamb, and today we will be discussing hyperthyroidism for primary care of geriatrics. The objective of this presentation is to understand the pathophysiology, some clinical findings, treatment, the diagnosis and testing criteria, how this is relevant in geriatrics, and the care team involved in treating hyperthyroidism. In hyperthyroidism, there is too much of the thyroid hormone that is excreted by the thyroid gland. This causes a low TSH and a possibly elevated T3 and/or T4. Common causes of this condition include Graves' disease. This is an autoimmune disorder that is the most common cause of hyperthyroidism, and it is more commonly found in the African American population. A toxic multinodular goiter is also a common cause, nodules present on the thyroid, and then iodine and medications such as amiodarone and lithium can also cause hyperthyroidism. Risk factors for hyperthyroidism include your gender. Women are more likely to have hyperthyroidism than men. A family history of any type of thyroid disease. Stress can increase your likeliness. Infections, specifically viral of the nature. History of smoking, high iodine intake, or the presence of another autoimmune disorder can raise your likeliness for having hyperthyroidism. Hyperthyroidism can cause many different clinical findings due to the hypermetabolic state. Overt hyperthyroidism can also be noted to have more prominent symptoms than mild hyperthyroidism. Some common clinical findings are a thyroid enlargement or goiter, weight loss, increased appetite, sweating or heat intolerance, thinning of your hair and nails, cardiac findings due to increased cardiac output, which are AFib, tachycardia, palpitations, systolic murmur, and cardiac failure. You can also note vision changes such as lid lag, where the eyelid doesn't smoothly follow eye movement, blurred or double vision, and then exophthalmos or bulging of the eyes. Multiple soft bowel movements per day and urinary frequency increasing are also symptoms. You can also notice nervousness and shortness of breath, change in mood, concentration, difficulty sleeping, and fatigue and weakness may also be noted. There are both pharmacologic and non-pharmacologic treatment measures used for hyperthyroidism. Pharmacologic treatment measures are usually anti-thyroid drugs that aim to decrease the synthesis of the thyroid hormone. Thionamides, PTU, and methimazole are used, and then radioactive iodine ablation can also be used. Beta blockers are used in symptom management rather than the decreasing of the hormone. Non-pharmacologic management is surgery. This can be a thyroidectomy if the medications are unsuccessful. When diagnosing a patient with hyperthyroidism, the provider should obtain a thyroid function test, a good history and physical exam, and we should always know the clinical presentation so we can find the correct cause of hyperthyroidism. A thyroid stimulating hormone, or TSH, with the T3 and T4 reflex if the TSH is low is appropriate. A low TSH is less than 0.05, and the T3 and or the T4 levels may be elevated. Other testing or procedures may include ultrasonography of the blood flow to the thyroid, radioiodine uptake and scan to determine if there is a toxic multinodular goiter, and then a thyrotropin receptor antibody. This can confirm the presence of Graves' disease. Hyperthyroidism in geriatrics. A symptom commonly noted in geriatrics with hyperthyroidism is apathetic thyrotoxicosis. This is when the patient notes weakness or lack of energy. However, many geriatrics experience the same symptoms of hyperthyroidism as the younger population. It can be noted that these patients are not as likely to have a goiter as other patients with the same condition. Symptoms commonly found in geriatrics, however, are weakness, constipation, tachycardia or atrial fibrillation, weight loss, shortness of breath, edema, or decreased appetite. Many interdisciplinary care team members may be involved in the care of a patient with hyperthyroidism. The primary care provider may need to make referrals to an endocrinologist if a patient is resistant to initial treatment or the provider feels like a more intense therapy is needed. Surgery if there is a need for a thyroidectomy. This is usually the last result and only after pharmacologic treatments have not been successful. They may need an ophthalmology referral if the patient has visual disturbances due to Graves' ophthalmology. This can be double or blurred vision or exophthalmos. And I also wanted to note that financial disparities may inhibit the patient from receiving the appropriate care. It may also make it more difficult if they have limited access to quality care. This can cause a difficulty to find the correct and appropriate treatment. And these are the references used for today's presentation. Thank you for listening to my presentation on hyperthyroidism.